Final speaker this morning is Dr. Travis Rieder. Dr. Rieder received his doctorate from Georgetown University and is Assistant Director for Education Initiatives and Research Scholar at the Berman Institute of Bioethics at Johns Hopkins University. He is also a faculty affiliate at the Center for Public Health Advocacy within the Johns Hopkins School of Public Health. Dr. Rieder is a prolific writer and speaker on the topic of opioid use and abuse, and recently co-authored a special publication of the National Academy of Medicine on physician responsibility and leadership to counter the opioid epidemic. Please welcome Dr. Rieder.
Well, thank you for coming. I realize that I'm the last thing standing between you and lunch, and so I regret that time slot, but we'll try to keep you motivated going through. So my PhD is in philosophy. I always feel a little bit outside of my bubble when I come to things like this. And so what I'm going to do is I'm going to give you a kind of different perspective than what you've been hearing so far. So almost all of my work for the last 4 years, almost all of my scholarship and writing for the public has been about ethics and policy questions raised by opioids kind of writ large. And so working as a bioethicist at Johns Hopkins, one of the things that I hope to do today is kind of help us frame this issue. And so I'm going to start much higher than we've been. We've all kind of been diving in, heroin vaccine, cocaine vaccine, what are some issues with, doing the research trials. I'm going to start about 30,000 feet above that and ask some kind of basic questions about what sort of ethical issues should we even be talking about. So here's the real big question, how to do the bioethics of something like an opioid vaccine. And so there are at least two questions we could ask. The first one is, should we do this at all, right? And then the second one is, if we have an affirmative answer to the first, how should we do this? And the reason I put this out there is because I don't think it's obvious that we should do this, which makes me an odd speaker for today, I recognize. But insofar as it's happening, we should work really hard to do it as best we can, right? Think very clearly about, are there ethical issues being raised by the prospect of doing this, the fact that we're dedicating resources towards it, that this is the sort of moment we're having regarding the drug overdose epidemic. So those are the sorts of questions I'm going to ask. Now I recognize where everyone is fighting with the clicker here. Okay. So the first question is, what is the case for opioid vaccines? And since we're talking about trying to make concrete progress, I'm going to spend less time on this. But you'll get a sense that I have a view here. But what I want to do is then I want to take that view and ask a little bit more, can I be helpful in this moving forward? Boy, this clicker is going to cause me problems. Okay. So here's a preview. First up, an admission. So I've got an admission, then I'll preview my thesis. So the admission is that I'm actually a bit skeptical of substance use vaccines. And so I put these in scare quotes for a reason, because I'm going to talk about this language of vaccines. But that doesn't mean that my goal today is to be like, we shouldn't do this. That would be very strange, since Gary talked about he's however many years into a heroin vaccine project. So my admission is that I'm a little bit skeptical, and the reasons for this are really straightforward and at this higher level. So I tend to work in public health ethics, in clinical ethics when it comes to opioids, and so there's this big question of resource usage, right? And the kind of very beginning of a moral prior in this conversation is good estimates on my view are that we need something like $100 billion to combat the drug overdose epidemic. And most of that has to go to things like scaling up of treatment that we know works and harm reduction efforts. So that just doesn't leave a whole lot of resources and effort to go to new sorts of things, because we actually know what can work that's already super underfunded. So that's like the background of the skepticism. But I also really want to be helpful, and I recognize that this is something people are really excited about, and so I do want to try to say something a little bit more concrete. And so this is the thesis that I'm going to argue for today, that the pharmacotherapy that we're talking about, the drug under consideration, isn't a vaccine and shouldn't be called one. Now, I recognize that we've already been talking about a vaccine all morning. It's in the media. It's published in the literature, so I'm not like calling anybody out or saying like, oh, that was wrong. I'm just saying that there are good ethical reasons for noting that this just isn't straightforwardly the case, and that it can be misleading. And so one of the ways to be really helpful about what's the best way to move forward is to think like, what does this drug actually do, and how should we think about it, right? Okay, so backdrop, lots of different drugs are involved in the drug overdose epidemic, so you hear the language of opioid epidemic. the narrative that we've learned a little bit about already from Ross, especially a very good overview this morning. There was a really strong role that prescription opioids played from about mid-1990s to especially around 2010 to 2012. But one of the things that's happened in the last 3 to 5 years is that illicit opioids like fentanyl, the illicit version of fentanyl, and heroin has really taken over the opioid drive. But also, opioids just aren't everything that's going on. There's a lot of cocaine usage is going up, methamphetamine usage is going up, concurrent use with benzodiazepine is going up. So if you look at the Wonder data from CDC, multiple drug interactions are actually present in a lot of these overdose deaths. Okay, so that's just one backdrop to think in terms of. So one thing to note is we have all of these different drugs that we should worry about because the epidemic that's killing people and causing massive suffering in the form of addiction and housing crisis and homelessness and poverty and hopelessness, all of the kind of behavioral and psychological sequelae in addition to the fatalities, right? Some of that is not due to opiates or opioids. And we actually already have drugs for opioids, right? So this is a really interesting feature that came out a little bit in Tom's presentation. So like one of the things about that was really a good reason to push for a cocaine vaccine is because there's no actual treatment. There's no maintenance treatment for cocaine. But we have maintenance treatment for opioids. So because of that, I think we ought to be thinking about what this drug does against the backdrop of existing FDA-approved MAT, medication-assisted treatment, or MOUD, medication for opioid use disorder. So we have the maintenance treatments, methadone and buprenorphine. Methadone, I assume this is a pretty up-to-date audience, but I also don't want to leave anyone behind, so just to be clear, methadone's a full opioid agonist. It fully activates the opioid receptor. Buprenorphine is a partial opioid agonist, has a ceiling effect on respiratory depression. It's a very good, very safe drug, but it still does a lot of what methadone does in terms of providing a stable dependence that evens out the brain chemistry, reduces some of the cravings. And then we have naltrexone, which is totally different from the other two, right? It's an antagonist, so it sits in the opioid receptor, but blocks opioids from engaging. So it sits in the receptor, but doesn't activate the dopamine system. So here's a question. Where does the new medication that we're talking about fit in, right? So we already have these three, and now we're talking about this language of vaccine. So where does a vaccine go? How does it compare? What does it bring that's new to the table? What are the different pros and cons, right? So here's a really important question to ask. And this part has already been brought up this morning. I think everybody seems to be on board with what I'm going to argue in regards to prevention and treatment. But I'm also going to show that much of the population who's actually heard of something like a heroin vaccine is not on board with what's been happening so far in here today. And that's really important to an ethicist like me, right? Because messaging matters, language matters, the way policymakers and the public react to our messages as scientists and scholars matter. So here's a really important question. Is this drug that we're calling a vaccine, is it a form of prevention or is it a form of treatment for opioid use disorder, right? So the first thing that we should do is get to this point that I want to, so this is a discharging part of my thesis, right? The proposed drug is not actually a vaccine. And the reasons for that are that we have to ask first, what would it be vaccinating against? And so we call the one that Gary's working on a heroin vaccine. So you think, well, it vaccinates against heroin. But that's not how vaccines work. Vaccines are vaccines against a disease, right? And so what would be vaccinating against? Well, I'm going to show you some slides in a minute about the way the media talks about. It would be vaccinating against addiction, if that's the health condition that's relevant here. But no, these don't prevent addiction. They do something else. They sequester drugs in the bloodstream and keep them from crossing the blood-brain barrier and interacting with the brain, right? So vaccines work against addiction. Vaccines work against diseases. Addiction is the kind of relevant disease, but this is not a prevention for addiction. This is doing something else. I really don't know where I should be aiming here. Okay, well, we just leave them both up. Oh, man, okay. So, I promise I'm a good presenter normally. Okay. So addiction is not an infectious disease. And so we actually had this interesting conversation about, herd immunity, which is my next point. If there's someone working tech, just help me when I'm flying, just press the things. Okay. So addiction is not an infectious disease. It's a disease of habit. And that's really problematic, and it's hard to think about because habit implies choice, and we're not going to do the moral character assailing thing. It has to do with the brain, right? But the point is you develop an addiction over time when you build what we think of as pathological circuits in the motivation and reward centers of the brain. And so there's no herd immunity component to addiction in any literal sense, right? It's not that we're going to vaccinate a portion of the population and then the rest of the population who's immunocompromised and so can't take it on board is therefore protected. That's just not how this is going to work. Okay. So the drug's only a vaccine in some analogous or metaphorical sense. So I understand why this language was used, right? You're utilizing the immune system and instigating this antibody response. So I'm very grateful, by the way, I'm going to give proper thanks in the end, but I have a live-in immunologist at my house, my partner. So I was very grateful to try to figure out like what's going on with this drug, but it's the kind of metaphorical sense in which this is a vaccine. Okay, and then why this matters, and it's not just semantics, which I recognize like the worst thing for a philosopher is like, he's gonna get up and talk about semantics. Language doesn't matter. Okay, yes, so I think language matters here. And that's because calling something a vaccine helps to justify it. Vaccines in our society have moral clout. So if you call something a vaccine and then you enter into public policy discussion, you get something from that. Look, we have a vaccine. Don't you know about this whole conversation, right? You're supposed to vaccinate your child because it's a good thing, right? So vaccines can do something really amazing. They can eradicate a disease. You can get rid of polio, right? And you can protect others by vaccinating yourself. And so when you try to talk to parents who are vaccine hesitant, one of the things you can say is, look, this isn't just about you. There are children who are immunocompromised who can't take this on board. It's your job to be part of the herd that protects these people, right? So calling something a vaccine helps to justify it, but the drug under consideration doesn't do either of these things. It's not going to eradicate addiction. I'm going to talk a little bit about that, but if you don't already believe that, like, I'm just going to put this out as a bald thesis. We're not going to eradicate addiction no matter how good we get at these vaccine drugs, no matter how many are on the market, no matter how many you can take on at the same time. You are not going to get rid of addiction by pumping people full of vaccines. Now, none of this is to say, I realize I'm getting all excited, right? None of this is to say that we shouldn't be doing what we're doing. I'm going to come back to that. But we have to be super clear about what the goods are associated with this therapy. So, what's it do? It prevents a particular drug from fully engaging a user's reward center. It's a very specific thing that it does, right? And that sounds like a really helpful thing on a suite of medications, on a suite of therapies. So then we should ask, okay, so like what sort of other things could we do? Does that matter? Does it matter that it's not a real vaccine, that it doesn't do these things, and so I have this worry about moral clout? So here are a few of the headlines, right? researchers land NIH contract to develop opioid addiction vaccines. We're already getting the addiction vaccine, right? Developing vaccines to fight opioid addiction, NIH grant. A drug to end addiction. This is my favorite. Scientists are working on it. No, they're not. Okay. They're working on something really cool. They're not working on that. A new vaccine can make the brain immune to heroin and opioids, scientists say. You gotta get the immunity in there. The brain could be immune to this thing. Fighting the opioid crisis with vaccines and better chemistry. It's not horribly misleading, but I do want to say, like, we're fighting the opioid crisis with a ton of stuff. And most of it is scale up of methadone and buprenorphine treatment, embracing harm reduction, getting people clean syringes, right? This will be a very small component of what this country needs. A shot at blocking addiction. No. We're not going to block addiction. We're going to block a particular drug. Okay. The reason I get all excited about this and excitable is because addiction is super complex. It's real hard. It's real hard to figure out. It's real hard to treat. It's real hard to live with. It's incredibly complex. And I got my brain pictures up there mostly because I love my brain pictures. But we call this a chronic relapsing brain disease. We've already heard that language some today. There's actually genuine debate over whether that's helpful terminology. In my own work, I tend to avoid it. I say it's something like a health condition. What's really important is that this has to do with your health. One of my colleagues who's world-class addiction theorist, Hannah Pickard, she calls it a disorder of choice, right? But the point is it belongs in the health community. It's not a moral failing. It's treatable with medicine, and it has to do with these pathways in the brain. Right? So the brain can be disordered, it can be dysfunctional, it can get this pathological circuitry, whatever language we choose. and it's really, really hard to treat. We have to do a ton of things. We talked about these incredible relapse rates. I love the point Ross made in response to this last question. You can be using low levels of heroin every once in a while and totally be in recovery. Yes, this is clearly true, and if that blows your mind, we have to talk more about what recovery can look like. It doesn't have to be pure abstinence. There are countries, the UK actually, but also Switzerland, there are places where there's heroin-assisted treatment instead of methadone or buprenorphine-assisted treatment. If you have regular access to heroin, you can enter recovery because it stops dominating your life, right? So this is an incredibly complex disease, and the reason that I want to bring that up is because the idea that we can block addiction by making somebody less reactive to a very particular drug is reductionist. It simplifies it, and it simplifies it in a way that I worry can be problematic. Okay, the last thing on prevention versus therapy. Suppose you're a little skeptical of what I've been saying. I'm a philosopher, I'm used to that. Everyone's skeptical of everything I say. That's ethics. But suppose you're a little skeptical, you're like, okay, so surely there's something we could do to protect populations. So who should we protect? If we thought of this as a preventive measure, we could do a couple things, right? We could protect those at heightened risk, or we could try to protect the entire population. So the entire population is the route we try to go with, like the MMR, or measles, that sort of thing, right? But we might say, well, this is gonna have to be more triaged. So let's just think about some first initial ethical considerations about both of these. So those at heightened risk, well, we just said that drugs, well, we said addiction's really complex, right? So a really important point of that is that drugs don't cause addiction. Now, I want to be real careful about that. They don't cause addiction in the sense that it's not that you are exposed to heroin, that's a different thing. Okay, so you're not exposed to heroin and thereby immediately there's a direct causal chain that leads to addiction. That's not how addiction works, right? And so, as I think Tom pointed out, almost everybody in here has been exposed to opioids. And if you're like, yeah, but most of us have been exposed to heroin, that just actually doesn't matter that much. Like, fentanyl is more potent than heroin, hydromorphone is more potent than heroin. Like, I was in the hospital for months exposed to morphine, fentanyl, hydromorphone, oxycodone. I've been on all this stuff and developed a profound dependence. We talked about the important difference between dependence and addiction. That is to say, if you take it away too fast, you go into withdrawal. But I did not develop an addiction because addiction rates are actually pretty low, right? So the drug doesn't directly cause addiction. It plays a causal role. So if there are addiction risks, and different people have different levels of risk, other drugs can absolutely step in to fill this gap. It was an interesting observation that this didn't happen very much with cocaine during the trial. Happens everywhere today. The drug landscape of today is massive polypharmacy, right? And so a lot of people that are using cocaine are using opioids, so the speedball has come back with force. A lot of people are trying methamphetamines for the first time. Like, you can activate your reward center in lots of different ways. I'm also worried that this seems to endorse that reductionist simplistic view, right? And here's a big question that's being talked about all the time, this language of the opioid epidemic. You notice I haven't been saying that. I've been saying the drug overdose epidemic. If you keep talking about the opioid epidemic, we're going to miss the fact that methamphetamines are on the rise, that cocaine's coming back, right? What's next? Maybe it's benzos. Maybe that's what's really popular 10 years from now that's killing people. So if we aim at heroin exclusively, maybe we'll miss the next threat. And of course, it could be something that I don't see at all, right? And if we're looking specifically at those with heightened risk, I am worried about the risk of stigma, right? What we're doing is we're trying to find the population at high risk of addiction. Well, what's that group look like? How are we going to categorize those people, right? So we have intake surveys, right? We have things that stratify people according to risk. Are we going to put this in their medical records, right? This is recommended, right? So the risk of stigma, because we're identifying somebody as a high-risk group when addiction is a highly stigmatized condition, is something that I think we always have to keep in mind. Whoa. I don't know how that happened, but I'm going to leave it because it's too hard to click. And then the risk of coercion, so we already talked about you can't do research on prisoners, but once something becomes FDA approved, it's real popular to think about what we can do with prisoners, right? So would vaccines become the sort of thing that just become a condition of parole? You want your freedom, you're gonna let us inject you every 3 months. I'm not saying out of hand that that's wrong, but I'm saying it's coercive. And that's one of the jobs of ethicists, to think about whether or not when you dangle a carrot, when you give somebody a choice that they can't refuse, right, if that's problematic in a particular instance. So we have to think about racial bias, we have to think about all vulnerable populations. So stigma, risk of coercion, these things go together. They really worry me when we think about focusing on heightened risk population. And then if we go to the entire population, like we're actually going to use this as a preventive. I think it was Gary said, like, oh yeah, at the end of Gary's talk, I was very happy to hear him say, like, I don't see this as a preventive measure. But look at the media. Look at those headlines I put up. You call it an opioid vaccine, that's exactly what they're thinking. Thank God scientists are finally solving this. It might take every 3-month booster now, but they're going to get better because science is inexorable progress forward, right? And at the end of this, we're just going to be able to vaccinate our kids and no more heroin addiction, right? So the same point that we saw, addiction risk is low in the general population, so I'm not sure that's a great use of resources, even if it could be made to work. There are lots of other drugs. So if somebody really is bent on using substances in a chaotic way, there's lots more they can use if you give them a vaccine against heroin or maybe heroin and fentanyl. So then I've actually had this conversation with people. They're like, well, we'll get better at this and we'll just vaccinate people against everything, right? So are we really okay with that? So suppose we are really good at this. Like, I'm a philosopher, I'm allowed to play this game, all right? Forget the scientists who have all these problems. So thought experiment time. Suppose we have a perfect lifetime vaccine, or maybe you have to get a booster every 10 years, and we have it for all drugs of abuse, right? Should you just vaccinate your child against all of them? I don't think the answer is obvious, because we care about our kids turning into people who have freedom, who have autonomy, who can choose to act in different ways. You're like, do you really want them to be free to take drugs? I love alcohol. Anybody else in here love alcohol? I have an impressive whiskey cabinet. You're gonna vaccinate against whiskey? Obviously alcohol in general, but whiskey is what I'm worried about, right? You're gonna vaccinate against that? Marijuana is becoming really destigmatized now. We're all about marijuana solving all our problems. So we won't vaccinate against that one either. Notice what's happening. We vaccinate against the drugs we don't like. What's behind that don't like, right? We didn't like marijuana for a long time. Now it's cool. I am totally not on board with taking the idea that we are going to decide which drugs are good and bad, and it probably falls along classic racialized, stigmatized, terrible lines that we've been kind of brought in all sorts of stigma. So I think it's probably not the thing that we would want to do to reduce our children's choice in the future. And one thing to note, this is a case of pure paternalism. So when we think about public health ethics, we think about what justifies certain interventions. We tend to say you can't justify intervening on people's autonomy in a really severe way unless there's some other benefit to others. If it's just a benefit to the person, it's real controversial. So think about how hard it was to get seatbelts passed. We had to like sell people that it was about their kids watching and stuff. Like the fact that it was this tiny little movement that you had to do that reduced your likelihood of dying wasn't enough. And even if that's the actual reason that most public health ethicists were like, just buckle your freaking seatbelt, right? Even if that was the actual reason, we had to sell it based on something else. Think about smoking. Only the secondary effects on people like kids really got it going. We, by and large, don't protect people from their own choices purely. We have to bring in other sorts of considerations. Okay, so treatment or prevention. That was a really long argument for something that the other panelists seemed to already be on board with, but just in case not everybody had kind of gotten there, I just don't think this is going to be the sort of drug that can be or ought to be adopted as a broad preventive measure. So it's a form of treatment, and that's okay. But now, okay, so now let's go back to this. Where does the new medication fit in? If it's a form of treatment, we've got those. And now this is the part where I think we really need to do work. This is also just like paradigmatic philosopher. I'm like, I said a bunch of things, I want you all to do the rest of the work. Because I have some ideas here, but I don't have a strong view. And what I want to do is I want to provide a sort of framework that we could start thinking against. And maybe I get the framework a little bit wrong, but part of why I was so excited to be invited today was to think about the framework with you all. So I'd kind of initially put the vaccine just next to this, right, next to naltrexone. But that wasn't an accident. I think that's actually where it fits, because there's a line running through these treatments, right? On one side, you have methadone and buprenorphine, which are maintenance treatments. Whoop, oh no, you gotta see my pretty diagram. I worked so hard on it. Okay, you have maintenance treatments on one side, methadone and buprenorphine. They are opioid agonist treatments. They're replacing the opioid that people were taking and trying to reduce the behavioral problems that were harming that person. On the other side, we have abstinence-based therapies. Now, the caveat here is that I think there's really good reason for thinking that the best version of a vaccine proposed will have to sit somewhere in the middle because it should be used in conjunction with, say, a buprenorphine, right? But by itself, I want you to think about how a vaccine is described, especially to the public, because it matters, especially to policymakers who may not be experts, because it matters. It's blocking the effect of a drug. And that's just like naltrexone, right? It's doing it in a different way. Naltrexone sits in the opioid receptor. This keeps it from ever even passing through the blood-brain barrier. But it's an abstinence-based therapy. It's keeping heroin from ever affecting you. And I think that's really crucial. It's crucial for all those messaging reasons, but it's also going to help us think, like, we should probably be thinking about it in comparison with naltrexone. Vivitrol, the injection-based form, right? So if we want a good kind of comparison case, so Vivitrol is the brand name for the month-long injection base. So suppose they make it better so it lasts for 3 months, and then the vaccine comes out and it lasts for 3 months. You've got really similar drugs in terms of function. Now, what are the pros and cons of each? And I think there's actually a pretty decent case to be made for the vaccine, but I want us to think really carefully about it because this is how we decide who it's for. Like, what's the population actually for? How do we message it to the public? So for naltrexone, you get this feature, it blocks the opioid receptor. So the pro, it prevents euphoria and overdose while the opioids are, from all opioids while using. Now that all opioids is important because it's blocking the receptor. So you're unable to use a lot of opioid analgesia while the naltrexone is on board. It's a really important feature, right? So think about you're in recovery, you're using naltrexone as a bulwark against relapse, because that's what it is, right? It's undermining your motivation to use because you know it's not going to do anything, right? So this is for highly motivated people in recovery. And you're using naltrexone and you get in a car accident and you're wheeled to the emergency room unconscious. They're going to be looking at your traumatic injuries and thinking about what sorts of pain care you need when you wake up. And having naltrexone on board is a real problem because the oxycodone's not going to work, the morphine's not going to work, the fentanyl's not going to work, the hydromorphone's not going to work, right? So if there are docs in here who do this, I'd be interested to hear what your actual protocol is. I assume that it's something like ketamine, but I don't actually know. This is where my expertise ends. So that's a really helpful pro-con to think through, right? It also has decreasing effectiveness over time. So my understanding of the injectable form of naltrexone, it spikes, and then over about 4 weeks, it slowly reduces its effectiveness, and then you need the booster another month later to reach full effectiveness again. So now compare this to the vaccine. So you're doing specific drug sequestering, although I was so happy to be here for Gary's presentation. He did kind of indicate at the end, we might have developed a real opioid vaccine instead of just a heroin vaccine, which I was thinking the fact that it could be just heroin might be a real feature, not a bug, right? Because you could still use opioid analgesia while you have the vaccine on board. If oxycodone or oxymorphone or hydromorphone work, you can be vaccinated against heroin, maybe heroin and fentanyl, still use something like oxymorphone or hydromorphone. That would be really helpful. But probably way more helpful than that is that you can use MAT. And that did bear out in the mice data that Gary showed us, that still methadone and buprenorphine were completely ineffective. So here's a really good case for it. Somebody wants the bulwark against relapse, but they also aren't ready to be an abstinence-only program. Keep them on their buprenorphine and put the vaccine on board. That's a really promising sort of case, I think. So this is the question that I asked earlier, that the immune response can be overcome. So that's just kind of comparing the effectiveness. So naltrexone has this decreasing effectiveness. The vaccine has this immune response that can be overcome. It's also variable by individual, we heard. But true of both, true across the board, these drugs don't fully treat addiction. Just say it. Just keep saying it 1,000,000 times over. Everyone you talk to, they don't fully treat addiction. They're doing something specific. How do we advertise naltrexone to people? It's a bulwark against relapse for highly motivated individuals. We hope that it reduces cravings. One of the mechanisms by which it can reduce cravings is that when people relapse, and we kind of assume they will because of these statistics, you inject heroin, you've got naltrexone on board, nothing happens, you break the reward habit link, right? And if you do this enough time, you start to unwire that circuitry. So the same sort of thing could probably be true of vaccines. We're not going to have data on this for a while, but it doesn't fully treat addiction. And so, yeah, we're going to need counseling. We're going to need wraparound services, all the sorts of things that we think of with MOUD nowadays. And it's really difficult to initiate naltrexone. So hold off on the vaccine for a second. If we think about it as an abstinence-focused therapy as well, this will be true. The one thing that I'll say to Tom, this off comment about withdrawal is a bad case of the flu or a bad day of the flu. So I I will just say, a few people in this room know, I wrote a book because I went through withdrawal, and it was absolute hell, and I thought about killing myself. Withdrawal is terrible, and what's happening now is there's a population of legacy chronic pain patients who have been on opioids for a really long time who are being forced tapered because doctors are afraid of these pills. And so we're getting an enormous population of patients who are doing long-term opioid therapy discontinuation. And there are suicide cases already coming forward from rebounding pain, from withdrawal, from hyperalgesia, right? And so this is so severe that the FDA and the CDC this last spring have issued responses. The guidelines from 2016 CDC were not meant to force people off of drugs. The withdrawal is bad enough that people will sometimes kill themselves. This is a seriously adverse consequence. So what does that all have to do with things? Right? What it has to do with, to get on naltrexone, you have to be abstinent. And so you have to go through withdrawal. And that's just one of the barriers. And so when somebody is on methadone, buprenorphine, or naltrexone, the data is similar. Reduces all-cause mortality by 50 to 75% on the various drugs. Naltrexone is just as effective once you get onboarding. But if you don't start from there, if you don't start from the onboarding, naltrexone is not nearly as good as buprenorphine or methadone because it's so much harder to initiate, right? So if we think about the vaccine as abstinence-focused, we're going to face the same problem. It's going to be difficult to initiate. People are going to be forced with withdrawal in the future. That's a terrifying prospect because everybody on opioids for long term has experienced withdrawal at least somewhat. If they're daily heroin users, they get it all the time. If they're on chronic opioid therapy, they've been traveling and lost their prescription and gone 2 days. Like, everybody knows what withdrawal is like, and they're terrified by it. And so facing that is a huge obstacle. So this might actually be part of the case for heroin vaccine if you can think about it as an adjunct to maintenance treatment for a lot of the population. This might actually be making one of the strongest cases that I can think of for the vaccine. All right, closing out, I promise. So what kind of drug is this? Who is it for? What is it? Not a vaccine. You guys see, I got a bone to pick, right? Sorry, okay. Not a vaccine. So let's come up with some new terminology. I came up with new terminology because I like to do that because I'm a philosopher. But maybe my terminology sucks, maybe it's scientifically inaccurate in some way, I don't know. So here's something I'm throwing to see if it sticks, right? Drug sequestering therapy, DST. So another form of MOUD, we have maintenance therapies, we have OAT, opioid agonist therapies, right? And now we have a drug sequestering therapy, a DST. It keeps the drug in the bloodstream, keeps all of it from passing through the blood-brain barrier so that it reduces effectiveness. Interestingly, if you take that as a pretty broad description, I don't know if that would actually cover naltrexone too, right? Because it could sequester the drug outside of the brain's receptors. Anyway, I don't care if anyone takes my terminology. It was just, I'm saying we shouldn't call it a vaccine. What should we call it? That's one thing we could call it. So it's more honest. I think it's less likely to mislead people, mislead the public, mislead policymakers. Who is it for? I don't know, not with 100%, but here's really the central claim. I kind of buried the lead a little bit. The central claim of this talk is, I think this is what we really ought to be doing. We ought to be trying to figure this out. Because it's not a magic bullet. It's not going to block addiction. It's not going to make us immune to addiction. It's not going to solve addiction. It's not going to do any of the things that the media is going to be tempted to say, especially in headlines, because they get more clicks, right? That's not what the drug's going to do. We're going to have a population for whom it's more effective than other drugs, hopefully. And that's the population that we should be targeting, right? So I think it probably has to be a highly motivated person entering recovery because you are choosing to take on something that is a bulwark against relapse, right? It's a really hard choice to make. When people go on to methadone, buprenorphine, sometimes it's like a borderline coerced decision. They're incredibly sick, and this is the thing that they can do right now. And that's a great, so my colleagues in addiction medicine call this a reachable moment. Instead of a teachable moment, it's a reachable moment. Somebody comes in the depths of withdrawal, and it's one moment where you can say, I can make you not be sick anymore. Let us try inducting you on buprenorphine and see if this works for you, right? But you have to be really highly motivated. You have to be much more planful if you're going to take on something that is a bulwark against relapse. You have to decide, I'm never doing heroin again, and this is my plan to do that, right? And so then the question is, it looks an awful lot like naltrexone, so what separates it? My hypothesis so far, but I'm not a scientist, my hypothesis so far is that from what I can find in the literature, maybe the best case to make for it is that you can use it alongside these maintenance therapies, and so you're just improving naltrexone, really. If this worked as well as it could, we wouldn't need naltrexone because this would work better. It would be a bulwark against relapse that also allows you to take maintenance medication, right? And ideally, but Gary's data kind of threw me off, maybe it would even not mess up you going to the ER and needing to take standard opioids. Okay. Thank you very much. I have to acknowledge Emmy Hood, who was he's a research assistant in the Berkman Institute of Bioethics, who helped me for the last month or so as I've been thinking about this. And Dr. Sadia Amjalu Rieder, who has a very similar last name to mine, is an immunologist who happens to live in my house. And I really am grateful to her for helping me think through this. Thank you much. Happy to take questions.
So thank you so much. You're right on in terms of the considerations and your thoughts. I think it's very appropriate. It's helping us refine the conversation. So I wanted to share some thoughts with you. I have two things going against me. I'm infectious disease. I'm a vaccinologist. So I do think of it in terms of that way. First of all, I think that the justification for any vaccine, and I still use that terminology, really goes back to establishing what the burden of disease is and what the economic impact of a disease. And we measure it in several ways, whether it's dailies or qualities or whatever. I don't think there's any question that heroin specifically is probably got the largest economic burden and impact just by one loss of life, 70,000 last year, 500,000 in the last decade or so. So I think there's a huge justification and burden of disease for something very specific against heroin. So I think that argument can be made very well. In terms of how to think about it, I think when we were talking about the heroin vaccine, we were thinking in exactly that way, that this is an equivalent of Vivitrol. In fact, you could take the investigator's brochure for Vivitrol, do a find and replace, and put heroin vaccine, and I think that would be exactly the way that it should be used. And you're absolutely right, it's not meant to treat or cure addiction. But even in the literature with Vivitrol, there's been several papers that have shown that Vivitrol in conjunction as a adjunct therapy to recovery have shown that people on Vivitrol have had lower relapse rates in addition in a recovery program. So potentially that a vaccine could work in the very same way as an adjunct in improving recovery and sobriety. The thing is that with Vivitrol now, it's entered into the justice system. So there isn't a conditional release, but there is an implied release for those who want an early release if they take Vivitrol. So I worry about the ethical considerations behind that and having the vaccine replace it. But, you know, we really haven't talked about its prevention. So there are subpopulations that are very high risk for specifically heroin addiction. And if you could prevent that initial high from heroin, could you prevent addiction long term? So I guess my question to you is, in all respects, don't you think there might be a very important use of the vaccine as a replacement for Vivitrol and probably a longer durable replacement and probably a cheaper, but also in targeted subpopulations who might be high risk for heroin addiction?
Yeah, that's a lot of great stuff. I'm probably not going to satisfactorily respond to all of it, but it invites me to make a comment that I would want to make anyway, so this is really helpful. You help me give a longer talk. No, so one of my major concerns with the response to the opioid epidemic, the drug overdose epidemic, is a very strong focus on abstinence approaches by especially policymakers in the Justice Department. And so your comment that Vivitrol has now been entered into the justice system, that is exactly the sort of concern that I have. And so you have this feature that is really appropriate for a subset of people, for really highly motivated individuals who are ready to enter this sort of recovery, this abstinence-based recovery, right? And the focus, so it's not that abstinence is bad. I'm all for abstinence. If you're not taking heroin, you're less likely to get fentanyl spikes and die. You're less likely to die just from heroin overdose, although that's less common than when it's contaminated. I'm all for abstinence, but I really worry about the focus on abstinence because it leads people to say something like, methadone and buprenorphine is just replacing one opioid with another, right? which is not true, is replacing one opioid with another, but it's not just replacing one opioid with another, because it's replacing one that's destroying people's lives with one that helps stabilize their lives and recover from the addiction component of what they were doing, right? They maintain a dependence, but so does everyone on an SSRI. So I'm very concerned with our love affair with Vivitrol, which is not to say that it's a bad drug. I'm just concerned with how much we love it. And so I'm worried about the vaccine inheriting that love affair. I think it would probably be a really helpful tool in a suite of tools that has its place, and our job is to think about what's the best place for it to inhabit. Yeah.
It's important to expand on that point for those that don't know, because you said it, a little bit during your talk about how eventually those people who maintain themselves on intramuscular naltrexone or Vivitrol end up having relapse rates as low as the other medication forms. But why? So it's a great question. Who is this for? Because you're right, policymakers and pharma do, in fact, because I interact with both quite a bit, really focus on abstinence and where to put these medications. And what's important to know is, what's the big deal? Here's the big deal. The 2 to 3 to 4 times it takes somebody to maintain themselves in Vivitrol, during all those failures between the month 1 and 4, there is a large number of people that are dying in that study group, right? So when these studies are done, they say, even when you meet with the pharma, they say, look at this, if you get your 4th shot of Vivitrol, 88% will not relapse. And I said, well, what happened in the group of people who did not come back after 1 month? Well, we don't know. They just fell out of the study. And the point is that many of those people die from overdoses. So that's why it is important to really say, well, why not, where does this fit in? It is very important, because people will die early on in the failures if you say this is abstinence only. And that is what we actually see, and that is the realities of Vivitrol, is that to get to that point, there are people who are going to unfortunately fall off and die as a result of not being able to get to their 2nd or 3rd shot. And that's basically what Dr. Here was saying, is that these are things that we need to, to think about, even though it may be a helpful tool.
Yeah, I have nothing to add. That was perfect. Next. Yeah.
Thank you. Very nice talk, and I think does point to the fact that philosophers and scientists can have a convergence of opinions on things.
Every once in a while.
Every once in a while. Yeah. The one thing that is important to point out, though, is that fentanyl and the fentanyl derivatives actually have a different way that they bind to the opiate receptor. And the medications that we give out to override naltrexone or buprenorphine or methadone when people have a pain syndrome that opiates are the best treatment for, kidney stones are a good example, are the fentanyl derivatives, that they will override them. That also means that people who are on naltrexone, methadone, or buprenorphine are overdosing with fentanyl. So the vaccine that's really the focus that is most immediate is fentanyl, because we don't have any treatment for it, and we also have no way, and the people on the street know that fentanyl overrides those treatments also. But when they play with it, they unfortunately often get overdoses from it and die from it. So the fentanyl vaccine is the goal more than the morphine or other opiate vaccine is. And I think that will form a preventative intervention in a high-risk population, and that is fentanyl's also being mixed in with methamphetamine, with cocaine. In the South, at least, most of the overdoses with fentanyl are actually in methamphetamine abusers. So at this point, it's looking as if, let's say, when and if we make a fentanyl vaccine work, and it looks like it's going to be reasonably easy to do that, which is good. It will still, I think, only last 3 months, but getting an injection every 3 months is feasible. But probably everybody who's on methadone, naltrexone, buprenorphine, are methamphetamine abusers, are cocaine abusers, and possibly other drugs. They haven't started mixing fentanyl with benzodiazepines yet, but there's no reason they shouldn't. It may be that every substance abuser is going to need to get a fentanyl vaccine simply because it's preventing death. and that, because it's way too difficult. The way that people mix fentanyl with these drugs on the street is not by the good manufacturing practices that pharma uses. They instead get synthetic fentanyl, which is very, unfortunately, easy to make, and they put it in a cup. And in the old days, they used to take their finger and mix it around. They've stopped doing that because they realize fentanyl's absorbed through your skin also, and it will kill you while you're mixing it up. So instead, they put a glove on, and then they mix it up. Well, what that means, what you're selling, some of it has got a lot of fentanyl in it, some of it's got a little fentanyl in it, and when someone gets these methamphetamine, which is now increasingly what it is, with fentanyl in it, they say, this is the best methamphetamine I've had in a long time. Let's not avoid that dealer. Let's all go to that dealer. So we are, in fact, getting other things that resemble infectious diseases where there's the well that, you know, Mary got the water from, where everybody got typhoid, and everybody's going to the well. And so, yeah, so I think that this is, there's an aspect of this where I think with fentanyl we do have a particular drug with a particular mortality associated with it that probably will be almost a mandated intervention to, you know, because it's low level. So that's one thing I would just think about in this.
Yeah, I mean, now we're getting this specific, you know, so maybe it really could be preventive in a very specific population, preventive because it prevents overdose, not addiction. Okay, so now we're getting into where we can really do some ethics, right? We've got a specific case, a specific proposal. So I do have worries, so here are just a few. So the first one is, it's not counting against it, but we would have to be clear. It's no longer anything like an addiction vaccine, which I already said it's not, but now it's not combating addiction at all. Is preventing overdose, right? So the practice that you were talking about, like if it's just because fentanyl is highly fatal, now the purpose isn't to prevent a development of an epidemic of addiction, which is how a lot of people are thinking about the addiction treatments. Like, we have an epidemic not just of mortality, but of addiction in this country, right? And this would no longer be dealing with that. It would be trying to reduce the mortality of people's drug-using behavior, which is a fine goal. That's what naloxone does, by the way, right? So it'd be a harm reduction measure. Oh, that's really interesting. This would be, yeah, it would be trying to reduce the fatality of drug-using behavior, which would be interesting categorization. The other thing is, we go back to the point that I made about pure paternalism. This would be a seriously ethically controversial idea, that because there's no herd immunity, the idea is not that you're protecting people in a community from somebody. You would be forcing, so you said mandated, you'd be forcing people to take it for their own good. And you think about how hard it was to get people to put on seatbelts, right? You want them to go and get shots every 3 months, or take their kids to get shots every 3 months. It's a violation of bodily integrity. It's in the hospital. It's, you know, kind of think about the populations that you're thinking about. If any of them are vulnerable populations, think how it looks against a history of systemic discrimination, right? So I have worries about the kind of mandate for a population. The last thing that I wanted to point out was addiction, fentanyl. It's too long.
You served my purpose, which was to get a controversial part into this.
Yeah.
It's like we got it.
Yeah, no, I think we've got it. I think there would be some serious pushback against that, yeah. Who am I looking at?
We might not have time. My question is about endogenous endorphins and whether the opiate vaccine versus naltrexone has a differential effect on those.
Oh, it's such a good question. I don't have any idea. Do any of the scientists know? It's such a good question.
The question of
Endogenous endorphins and whether naltrexone blocks them and or whether one of these vaccines blocks them.
yeah, I do have an answer. All of these vaccines have been tested against the various endogenous neurotransmitters, and the peptides, of course, are so large that they wouldn't bind at all to these antibodies. So beta endorphin or the enkephalins wouldn't do that. The worry had been with the methamphetamine vaccine, which is another one we're working on, that very much looks like dopamine or norepinephrine, those neurotransmitters. And we've had to eliminate some particular adjuvants that may generalize so much that they will bind those neurotransmitters. So yes, that's the one where it is an issue, but not with the opiates. The thing that happens with naltrexone is that beta endorphin and enkephalins are what those opiate receptors were meant to bind to. And so none of our external drugs like naltrexone or morphine can displace beta endorphin. But what they will do is quite fascinating. There's about 100 times more postsynaptic than presynaptic receptors. Anybody who knows what I'm talking about, that's great. If you don't lose too much sleep about it. But the presynaptic receptors are feedback inhibition receptors. When they are blocked, you pour out things like beta endorphin. So when you give naltrexone, you actually raise beta endorphin levels in most people about 30 to 40%. There's a genetic polymorphism, and I was alluding to genetics that we've been studying, that occur primarily in people from northern latitudes. Blonde-haired, blue-eyed people carry, about a third of them carry this genetic polymorphism. When they get naltrexone and they block those presynaptic receptors, they get about a 10-fold enhanced effect of the beta endorphins. The reason is that they have a 3-fold increased sensitivity in their mu opiate receptors. That was the discovery. Then they also have a great, because they only need a third of the amount of beta endorphin, let's say, to stimulate those receptors, they have a great excess of beta endorphin. So they, in fact, release, when you block presynaptic receptors, a 3-fold or 300% increase in beta endorphin levels instead of 30%. That has a whole bunch of implications of how those folks are very, very susceptible to developing addictions of a wide variety, including alcohol, because alcohol releases beta endorphin through an opiate mechanism. So I could give a whole, maybe I should, I could give a whole other lecture about this, but in fact, these vaccines don't affect any of those endogenous systems because they just don't let it. But naltrexone, in fact, does affect those endogenous systems. It also has effects on hormones, quite a number of them, that are problematic in adolescents. And adolescents are where we often want to use naltrexone as a blocker because they're early in addiction. But if you give it to them, in women you have the most problematic issue, which is it is a stimulus for ovulation. Opiates are inhibitors of ovulation. So what you get is young women who say, oh no, I don't need birth control. I never have taken it since I've been an opiate addict, and I've never gotten pregnant. And they get on naltrexone, and the next month they're pregnant. Because you of course told them to take birth control, but like mandating most things, it doesn't work. So there are a variety of things in here that in fact, there may in fact be reasons to pursue vaccines that would not have these side effects.
One more? Sure.
Thank you. In the spirit of the topic of today, ethical and regulatory issues, I have an ethical and regulatory question. So is there consensus among all of the presenters so far that the FDA ought to allow harm reduction, not just mortality prevention, as a criteria for drug approval?
Well, I think, yeah, we have to go around. Harm reduction gets a 100% okay for me. Yeah, that's the whole philosophy against the drug overdose epidemic should be a harm reduction philosophy, if you ask me.
The one thing you might want to think about is the FDA has adopted that position for alcohol. So that recently, meaning about 2 or 3 years ago, they agreed to approve a camprosate based on reduction in heavy drinking, and that's now another criteria. Before that, it was always abstinence was your FDA approval criteria. It has now changed to reduction in heavy drinking. What they're saying needs to be demonstrated with the other drugs of abuse is that if you reduce them to, let's call them, from heavy use to modest use, do you in fact get an improvement in overall health, mortality, et cetera? It has been surprisingly difficult to demonstrate that with opiates, even though you think you could. The other issue that has come up is that if it's inherently an illegal drug, cocaine is probably the best example, the federal government won't agree to anything resembling harm reduction. It's basically a dirty word to federal policymakers. So
although we're seeing a challenge with the safe injection sites, right? So
it's being challenged with opiates.
It's being challenged right now. We've got a first federal judge saying the crack house rule does not, safe injection sites do not violate the crack house rule. So like, if you're really on the harm reduction train, there are reasons to be optimistic right now, for the first time in a while, actually, yeah. All right, I think I get the hook, yeah. Thank you.